Welcome, everyone. Thank you so much for joining us on this Friday night on one of our most anticipated talks of HubWeek. HubWeek was founded 3 years ago is when we had our first HubWeek, and it was designed to show how the future is being built here at the intersection of art, science, and technology. And it's really the three of those combined. Walter Isaacson was actually our mentor in creating this because he articulated it so well that I just steal his words. And he said, the digital revolution, which disrupted our lives and how we work, play, connect, eat, it started as technology-based. How can we leverage technology? And the center of that actually was on the East Coast, and then the center of it migrated to the West Coast. The next real wave of disruption in this digital revolution is not just what technology can do, but it is technology combined with the science and combined with the arts together. And what we're really lucky is that we have strength in all three of those areas right here in Boston. And so HubWeek celebrates that. It celebrates the change makers. It celebrates the innovation that we have going on. And we have had an incredible week so far. And last year, Atul spoke at one of our sessions, and it was really mind-shifting. It was a discussion at Vertex where he explained his systems, and he was really impressed with the audience that he had, and we were so impressed with him that he was one of the first speakers that we booked for this year. And he and Malcolm, who are fellow staff writers at the New Yorker, are here today to explain and dive deeper into this really exciting topic. And to give you a brief bio on Atul, because he has done so much, but the broad categories is that he is an accomplished surgeon, writer, and public health researcher who inspires clinicians, patients, families, and policymakers to re-examine their understanding of medicine. He practices general and endocrine surgery at Brigham and Women's Hospital, is a professor at the Department of Health Policy and Management at the Harvard Chan School of Public Health, and the Samuel O. Thier Professor of Surgery at Harvard Medical School. He is the founder and executive director of the Ariadne Labs, a joint center for health systems innovation at Brigham and Women's, dedicated to reducing suffering worldwide through scalable solutions that drive better care at the most critical moments in people's lives. The stories that I heard about the work that he's doing stayed with me, and I'm sure we're going to get some of those tonight as well. Malcolm, who's going to be interviewing Atul tonight, is the author of 3 New York Times bestsellers, most recently David and Goliath. His podcast, which is very fun, is called Revisionist History, which recently launched its 2nd season, and it reinterprets overlooked or misunderstood phenomena from the past. I recommend downloading that. Gladwell has been a staff writer at The New Yorker since 1996, before which he was a reporter at The Washington Post. And I believe that Malcolm may have even inspired Atul to join. Before The New Yorker, he was at The Washington Post. In 2001, he was awarded the National Magazine Award for Profiles for his New Yorker piece, The Pitchman, about Ron Popeil. Please join me.
Malcolm and I are going to have a great conversation, but I thought I would set it up by telling you a little bit about the thinking that brought us together for this conversation, which is, I suppose I'm best known for the writing that I've done, but all along the way we've been doing some work here for 5 years now, launching a place called Ariadne Labs, and I want to explain a little bit about it. And the best way I can explain it is just by telling a story. So 5 years ago, I got a letter from Dwayne Smith, who was a 34-year-old grocery store manager in East Texas, who'd been in a head-on motor vehicle accident, 70 miles an hour. Another car crossed the dividing line, crossed over the median, and hit him while they were both going 70 miles an hour at the opposite directions. And he was all but dead. Broken leg, broken pelvis, broken arm, both of his lungs collapsed, internal bleeding, in shock, barely detectable pulse. We live in a time where the knowledge of how to rescue someone in that kind of situation exists. And like clockwork, a team arrived on the scene, brought a helicopter in, kept his blood pressure at an adequate level, transported him to the nearest hospital, and then step by step addressed every problem that he had. He was in shock. They took him directly to the operating room. They did an operation where they opened his abdomen, found the source of bleeding. It was his spleen, removed his spleen, stabilized his pelvis, stopped the bleeding coming from his pelvis. Now he was out of shock, and then in and out of an ICU for the next 3 weeks, getting each of his problems addressed. He spent several months in recovery, and it was all the consequence of a series of discoveries that we simply did not have even 3 or 4 decades before this, let alone have all of the pieces in place to be able to rescue someone like him. He's grateful to this day to be alive, but they missed one small step. So 2 years later, he was on a beach with his now 2-year-old daughter and his wife, and he got an ordinary strep infection. And this was a disaster, because the one small step they missed is that when you remove the spleen, there are 3 bacteria that you need your spleen for. And among the discoveries we've made is that there are 3 vaccines that can stop those bacteria, so you do fine without a spleen. But they forgot to give him those vaccines. And so that strep infection spread in his body unchecked. He ended up having septic shock, right back into the same hospital, and now he lost his feet, his fingers, and his nose. Lost his job, his ability to take care of his family. It was, he said, his worst vacation ever. When he crashed, he was cared for by good people. They had every technology, but they had no system. And to me, the most damning thing was that no one learned a thing from Dwayne Smith's case. No one learned anything from it, because we had the exact same thing happen right here in Boston at my hospital. And it's probably happened in every single hospital, only in our case, the patient died. We missed this basic step we were missing this basic step at least half of the time, even higher when you go around the world. So among the greatest tasks, I think, of our generation is making systems work. In our particular case, making systems work in healthcare and public health. And our challenge is that the volume and extreme complexity of modern know-how has exceeded our ability as individuals to handle it, to be able to master it and deliver it safely and reliably or efficiently to society. And complexity is the core reason why systems fail to work, why our system fails to seem affordable, why it fails to seem fixable either. A study from a few years ago showed that lack of execution is now responsible for at least 30% of deaths of people under the age of 75. 30% of people who die under the age of 75 are from conditions that are amenable to treatments that we have and simply haven't executed on it and executed on it correctly. We are all Dwayne Smith waiting to happen. We have now enumerated, a century ago we did not know all the ways the human body can fail. We have now enumerated 60,000 ways our 13 organ systems can fail, 60,000 diagnoses and conditions that human beings have. We have 6,000 drugs now, 4,000 medical and surgical procedures, And our job has been to deploy that capability town by town to everybody alive. It is, I've argued, the most ambitious thing that mankind has ever attempted. There is no world where we're trying to deploy 60,000 different services to everybody, town by town, with the complexity of what we're trying to do, and to do it the right way, humanely, and without regard to whether you can afford it. The big opportunity that we saw, putting my public health hat on, was that we achieved that century of breakthroughs, all of those breakthroughs that made that kind of care possible, the ability to live past 85 years. We have done it by applying science to our biologic systems. And 5 years ago, we made a bet that we could achieve transformative follow-through discoveries, not just the breakthrough discoveries, but the follow-through discoveries the same way, by applying science to our human systems. Our theory was it was not bad people, that this was a system disease, and that we could find the cure. So we founded a center at combining the Brigham and Women's Hospital and Harvard Chan School of Public Health as seeds that would bring together all of the hospitals across Harvard, and now extending to involve researchers from other hospitals, but then with people who are in research in the public health world, and economists, and people from the business school, and then people from nonprofits in the area like the Institute for Healthcare Improvement. That we gathered a Boston community that offered a combination of clinical expertise, design expertise, data science, program management, to tackle what was interesting to us, which was that there is a bell curve for performance in doing these things. It's not just that half may get that one step around giving the right vaccines for a splenectomy. It's that there's wide variation, and you can find places that are doing it right 99% or 100% of the time. And if we look at what those positive deviants are doing, the outliers, you could make simple, scalable systems that are capable of capturing what they do. Could be a checklist, could be a data feedback system, could be having a coach, and that you could deploy that at larger scale. We focused on 3 high-cost, high-complexity moments in people's lives that are important for everyone. Birth, how you come into the world. Surgery, your highest risk, highest failure moment in your life, and the average person has about 8 operations in your lifetime. And then your care at the end of life, how we leave this world. In every field that we've done this work now, it's 5 years on, we're coming out with the results in each of those fields, and what we've seen in every field is that taking that approach has had a dramatic effect on care. You can make it possible to get these things to happen right more than 90% of the time, more than 95% of the time, ultimately more than 99% and onward. And already we're saving as many lives and reducing as much suffering as the discovery of penicillin. So that's what I'm looking forward to talking to you about and having a conversation with Malcolm about, is understanding this under-recognized form of innovation, how it's done, maybe what problems still have left to be solved. So, and thank you, Malcolm, for letting me drag you up here. We're friends going back a long way, and yes, Linda's right. He was one of those who convinced me to try starting writing. So thank you for that.
That'll be on my tombstone, I'm sure. I wanted to start with the very last thing you said, that this is an underappreciated form of innovation. Why is it underappreciated? I mean, it's not obvious to me why we should be really interested in breakthrough innovations and not interested in follow-through innovations. Why these kinds of process things are the ones that get pushed aside. What's your reading of that?
I haven't completely figured it out. Like, we made a checklist for surgery. We deployed it in 8 cities. We ran it like a drug trial. The group who got the checklist had a 50% reduction in death, and so if it was a drug or a device, it would be a multi-billion dollar blockbuster, and instead, because it's free, it's not all that exciting, right? It's a checklist, so there's no IP, there's no patent on it. We happily give it away. On the other hand, so maybe the problem is a lack of a profit incentive, right? But your Android is open source. The software for that is open source. It's available and distributed. So that's not the story. And so there's something about the idea. We love rescue and heroism of being able to have something that, the cure, that the penicillin, I have my pneumonia, penicillin, it's an injection, it's simple, and it's done. And it's visible. The death that didn't happen is not visible. In the same way, the bridge that didn't collapse because it was built right is invisible. And I think it's fundamentally about that phenomenon that, the dog that doesn't bark in the night is...
But it is visible. So, is it Dennis Smith?
Dwayne Smith.
Dwayne Smith.
Dwayne Smith.
Dwayne Smith's injuries are very visible. Is it, I mean, it may not be visible to the people at the hospital who treated him, because the people who treated him and failed him may not have been aware that he had this side effect, this subsequent. But there's nothing invisible about what happened to him, right? There's nothing invisible about the person who dies on the operating table because some step was skipped.
Well, so think about this. Yes, his injuries are visible, but then when we get it down to a level that it becomes invisible, you no longer appreciate it. So in the same way, we're having a debate about vaccines now. Mm-hmm. We don't have the thousands of people who were paralyzed by polio. We don't have the millions of people who, young children who'd be infected by diphtheria, and you'd be worried that their throat would close up. We haven't seen tetanus, and so the idea that you're going to have vaccinations against these things has led people to say, why do we even need these anymore? And you have the backlash against the ability to prevent these problems that were once incredible scourges. And so I think there's something to the idea that you've acted ahead of a condition rather than rescue. Why do I get paid more as a surgeon to step in to stop a problem than the primary care physicians who would earn half as much as I do, preventing that problem from appearing in the first place?
If you, in that trial that you mentioned with the checklist, and you had mortality rates that are 50% lower, was there any way for the people who used the checklist and recorded those medical gains to advertise that fact? I don't mean advertise in a commercial sense, but to let the world know that they had such dramatically different outcomes?
You would think so. On some level, part of the reaction the public has to, so let me tell you what's on the checklist. It's 19 items. They're basic, probably the most important items on there is it's sort of like, it's like a football team. You have a huddle, you agree on what's the play. So everybody introduces themselves, because often you have a new team in the room at the beginning of the day. You introduce yourselves by name, you make sure the surgeons brief the team on what's the play, what's the goal of the operation, what are we gonna do, what's non-routine that we might be up to. The anesthesiologist reviews the medical issues of the patient that people might not be aware about. The nurse reviews the equipment, the sterile procedures. It's all like scripted, so you do it in less than a minute, and then boom, you're done, you move on. People's reaction when you find out that, okay, you cut deaths 50% by doing that, you weren't doing that in the first place? Like, it sounds so kindergarten. And now, and then furthermore, to be able to say, like, yes, we're doing the checklist, almost instantly as it went out, everybody said they're doing the checklist. We just completed a trial after 5 years in South Carolina. Everywhere said they're doing the checklist, but we would do observations, and most of the surgeons really weren't. They were officially doing it, it was policy, but they weren't. So we implemented, we carried out a strategy to get people who don't like to do the checklist to do the checklist. And then the hospitals that were taking care of 40% of the population completed the program, and they lowered their death rate across the state by 22%. So, they all would advertise that they're doing it, but it's still, different whether you are or not.
How much of this resistance is specific to medicine? Because I can point to lots of areas, not lots, but here we are in Boston. One of the best football teams of the last 50 years is a few miles away. If there was ever an organization that is committed to systems thinking, it's the New England Patriots. In fact, it's any successful football team. Everything that you've been talking about is second nature on the football field, right? You pay attention to every little detail. Everything is practiced, choreographed, scripted, down to the. So why is this is a rare case?
Down to the Belichicknick.
Yes, down to the. This is a rare case where football players appear to be smarter than physicians. How do you account for that?
Well, the couple things. One is, let's go even farther. Go to the aviation industry. The first checklists were begun to be used on a systematic basis in 1935, when the B-17 bomber, really the military first started using checklists there. But even into the 1950s, Navy pilots said, this checklist bullshit. And 1 in 4 Navy pilots died on the job. Like, you can't have a better incentive than that, you die. And therefore, but it wasn't until the 1980s in the aviation industry that people were actually using it. You wrote about, the power gradient and how in Korea, you still had captains who said, somebody else do it, I don't do this thing. And part of it is, we surveyed, for example, surgeons and asked them, after 3 months of using the checklist, did it take too long? So basically 80% said, 75-80% would say, in the end, it didn't take too long. We actually did have cases where it prevented something going wrong, and I think it probably was a good idea. But 25% thought it was a terrible idea. It was a waste of time, took too long, didn't do any good. And then we'd ask them, if you were having an operation, would you want the checklist? 95% did. And I think that part of it is the belief that that it doesn't apply to me. This is not my situation. Mm-hmm. And then it's just, a pain in the butt that somebody's. What
were the characteristics of the 25% of surgeons who resisted checklists? Were they distinctive in some way?
We never dug down. We never were able to dig down deep enough. We've always had a theory that some of it was generational. So, for example, virtually all surgery residents are come through now with it kind of being the standard of what you do. I remember when the supermarket scanners came through. I was growing up in Ohio, small town. There was a local grocery store, and the scanner arrived, and you'd go through the line, and the cashier would be complaining like, "This thing is lousy. I'm better than this thing." Would sit there like banging away, typing in everyone, sure that she's better than the scanner was going to be. And then, another generation came, and it was inconceivable you would go backwards. And so we're in that stage where, it's like asking people to change how you feed your child. There are better ways to feed your child than the way we feed kids today. But someone telling you, this is what you have to do, it inspires, this is my domain. And so part of it's a values thing. Autonomy is our highest value in the way we build medicine. And so you go to an operating room, and the surgeon's like, this is my terrain. And this is a direct challenge to that value. And there's real doubt and resistance that says, I'm not sure that giving up this value is good for patients. And the flip side of the value is what you're selling with this thing is that humility, discipline, and teamwork, doing certain things the same way every time, working with a team of people and activating them, and having the humility to say, no matter how great I am, things go wrong, is the set of values you're being asked to enact. And I think that it's about, it's people who are worried that you are losing something really important there.
Mm-hmm. Are surgeons, you've been talking about surgeons, are they the most resistant of medical professionals, or?
No, we're doing work now in childbirth, for example, where it's again a kind of checklist-based thing. There's 7 known ways that moms and babies die. The predominant ways, over 99% of the issues are infection of the baby or the mom, for example, or bleeding of the mom or the baby not breathing. We've had almost a century of having the solutions to each of them. And so structuring them into a kind of script and a way of moving through it inspires resistance at every level. Whether it's the nurses who are being asked to get to inculcate those kinds of habits, the procurement clerk that now has 22 drugs they got to make sure is at the bedside every time, the leader of the hospital who has to think about how you make those things happen. There's leadership commitment, there's the culture and what the values are that's there, and then there's getting the processes right. And if you have a commitment of leadership and even a modicum of a non-punitive culture, these things move. And our surgery checklist now is in well over 100 million. So our study was published in 2009, and running these is learning the ways to make it move at large scale. We're now past 100 million of the 300 million operations done worldwide are with our approach now. So making it happen was about first getting to the early adopters. The challenges are the middle and late adopters, and sometimes you just leave the late adopters alone until later.
Yeah. How did you come to be so interested in this particular topic? Were you always, or was it something that emerged after you became a surgeon yourself?
I think it was writing. It was really, so I started writing. You persuaded me to try it, and our friend Jacob Weisberg did as well. And I was a third-year resident, and I was interested in the question of what it meant to be good at anything. How do I get good at what I do? And that meant grappling with, at that time, the first question was, how do I deal with the fact that I'm learning on the job? It's on-the-job training in surgery. How do you have permission to be imperfect? And what's the way you understand that? And I think this has all been part of a discussion of what does it mean to be good at what we do in general in the face of extraordinary complexity of skills and knowledge we're asking people to execute on, your own imperfections, and being realistic about that, and what are the ethics and the expectations of that, and then the reality that we're shifting into a world where being a craftsperson in any kind of area is rare. You are now usually part of a group of people that are necessary to make anything happen, and getting to how do you make that transition from we rewarded, trained, and hired people to be cowboys, but it's pit crews that we need now, and no one wants to be a cog on a wheel. Like, how do you have individuality while subsuming yourself inside the pit crew? We all want pit crews, but we don't want to be on the pit crew. I find these things really interesting, and a certain affinity, because I think you've found many of the same lines of...
We're not getting to me yet. We're not done with you.
Thinking.
I want to get a little bit more into your own motivation. Most people who become surgeons are not drawn to this. I mean, the proof is in the pudding. Surgery has clung to, and other medical professions, but has clung to the notion of the hero, right? Why you, of all people? I don't mean to put it that. I realize that came out wrong. But what is it about you? What is it about you that made you resistant to that kind of dominant culture of the profession you were joining, discipline you were joining?
God, there's so many things that'd be hard to pull apart. But I think among the things, it helped that I had an exit path for a while before I came to medicine. So you and I met when I was studying philosophy at Oxford, and was trying to get away from being the child of Indian immigrant physicians. My mom's here somewhere. Where is she? There she is. A pediatrician. My dad a surgeon. The expectation in that kind of family is you're going to become another doctor. And so I was trying to rebel by not going that pathway.
By studying philosophy at Oxford? That's Indian rebellion for you.
That's Indian rebellion. And it still managed to upset them. Neighbors would talk about my mom and dad, complaining in the grocery aisle at the Kroger's, like, what's going to happen to him? Sorry, Mom. And then worse, I then went and worked in politics. So I worked on the Hill and worked for a Tennessee congressman. I then ultimately worked in the Clinton administration, then worked on a Clinton campaign. And so all of those things, you know, I was fundamentally interested in how you make communities better. I bring a lot of that to my parents. I grew up in rural Ohio, a poorest county in Ohio, but in a college town in that county. And my parents were unusual among Indian immigrants there in being community leaders. Both my dad and my mom became head of the local Rotary, and they always raised us with the idea that you are part of being useful in your community. Mm-hmm. And that sense that by the time I came to medicine, I had thought I'd been raised to think about yourself as a citizen first, and the professional second. Mm-hmm. And I think I was coming into it. So second thing I think made a difference was in my very beginning of my surgery residency, my wife Kathleen was pregnant with our first child, and he was born prematurely. It was to be 5 weeks into the residency, and ended up being his birth date is July 5th, and residency starts July 1. And he turned out to have a congenital heart condition. And I was spending that first month, and you don't get time off. It was back in the days of 100-hour work weeks, and so I would walk the bridge in my scrubs to children's hospitals, see my son in the ICU, and be a patient and a parent on that one side, and then walk back over to then ask permission from somebody to be their surgeon in their operating, to be the assistant, I'd say. I'm just assisting in the operation. And I think all of those jar you out of, I'm just following all the rules here.
Describe the kind of, you talked a little bit about the sorts of people who have resisted this way of thinking, but personalize it for a moment. What kind of resistance have you, or when you look back over the course of this long crusade you've been on, what kind of personal resistance have you run into? Has it altered relationships within the medical community that you have been?
Oh, I mean, look, I mean, I've had my own colleagues, like, you know, when I'm a resident starting to write about some of these ideas, and I've had, you know, attending surgeons who wanted me fired for doing so.
For writing about?
Yeah.
What was the basis of the complaint?
Oh, I'm making the profession look bad, or other things like that, right? So I was very worried about how I'd be received. But the huge part was that it was mostly received the way I was hoping, which was I was not trying to throw a grenade. I was just asking, how can I be good at what I do? And by extension, how can we all be good at what we do? And how do I face up to where I'm not good enough, which means we're all facing up to where we're not all good enough. And I couldn't have done it without the backing of, like, my chief of surgery had a completely different attitude. And he was a guy named Mike Zinner. You know, the hospital went ape. You know, the New Yorker, I'm writing for the New Yorker, it's my first piece, and I decided to write about a patient who I nearly killed because I made a mistake and couldn't get her airway. She had lost her airway, and I needed to do a tracheostomy, and I couldn't do it. And she just barely survived. And what I was trying to examine is, so was I a bad doctor? Was it a bad system? And how do I accept responsibility the way I need to? And so, you know, the Brigham just had to hear the words about what this was about, and from a second-year resident, like, why is this a good idea? And my chief of surgery, and so they said, we have to read it, and the New Yorker, of course, says, you know you're fired if you let anybody else read it. So I went to my chief of surgery and said, what do we do? And he said, I'll take care of it. And then he got permission from the public affairs department. He told them, I'll screen Atul's piece, and I'll tell you if there's anything wrong with it. And then he came to me and he said, I don't have to read your piece. And then he said, Harvard's a big place, and if you go down in flames, we'll still be standing. And that was exactly what I needed, right?
Yeah.
And yes, I survived, and then there would be a few people who were angry, but then the rest of the folks liked it. And they bought into it. I didn't get fired. I got offered to stay on and become a faculty member. And then eventually that surgeon, for example, who was the chief of one of our divisions, who wanted me out, became one of my best converts to it. Because who knows why? Over time.
Wait.
Over time.
That's super interesting. He went from wanting to fire you to becoming one of your best and you dismiss that with, who knows? Surely you've thought about that.
Think about like Bill Bennett, one of the most,
Your resistance to introspection, by the way, is rivaled only by my own.
Exactly. I was going to say, you're about to, the liberal convert to conservatism or vice versa are among the most vehement of believers, right? Because you want to, I don't know why. One of my reasons I think, so I can't explain exactly why, except that my intent is to stay in your face, but not be in your face. Like, I'm not trying to force you over. Mm-hmm. My theory about how this works is that if you build up enough people who are, you get the early adopters, and they are willing to become, if you have enough of that base of fans for whatever idea it is you have, then you get the middle adopters, and eventually the other folks come on board. And they come on board because there's evidence, because everybody else is around, or they find your flaw and they pick it apart, and they're the source of the next innovation. And so far, it hasn't. Most of my pieces have not blown up in my face, and
you haven't answered my question, not even remotely.
Yeah, but do you have a theory? Like, why would people come along eventually? It doesn't surprise me that they become the biggest fan, right? Converts do become committed. Like, they were committed to a point of view. You become committed to the other point of view when you make a change, right? You're not holding it lightly. You came to it through some serious thinking and thought. And so why you're willing to go through that and change your mind. People don't change their mind much. Mm-hmm. So when people do,
that's actually really interesting. I hadn't thought about that as a kind of, I always thought of there are people who change their mind and there are people who don't. But this is a much more interesting way to frame it, that all of us have
change our minds.
Have within us a certain number of mind changes. And maybe some of us run through those faster than others.
I have a lot of mind changes, right? So my favorite New Yorker cartoon was the gravestone that said, he kept his options open. and that's me.
What? And wait, let's talk about that for a moment. That's interesting. You like to keep your options open because it's more, now I will say, I have some affinity for this.
Yes.
Because it's more interesting to keep your options open, or because you're just sort of in awe of how wrong you are from time to time? Which would be, I would be the latter, I think.
You've written about optimizers versus satisficers.
I've actually never written about that, but I appreciate the shout out to my imaginary.
Have you never written about that? Okay, I'll give you credit for all kinds of things you've never done. I'm an optimizer, I think, so which means you're perennially unsatisfied and trying to move towards the impossible, perfect satisfaction. And the satisficer is satisfied, holds on to where you are, and takes a lot of effort to budge off. So I'm someone who, I love a new idea. I love a opportunity to rethink another avenue at another problem. Mm-hmm. I keep notes on my phone of cool new ideas, right? Mm-hmm. Mm-hmm.
What has been, when you
Which
think
is why
about...
I can't pick a restaurant. Because I think there might be another
better
restaurant.
Out there. When you think of the various projects that you have done, and let's be specific to Ariadne. What has been which one has been the hardest? So we know about you spoke about one of your great successes. Is there one that hasn't worked out the way you hoped, and tell us why?
Oh, so we have several. So we're 5 years in, and part of what we've learned is that you can look at the positive deviants who get better results, you can crystallize what they do, and then you can bring it back, and that you can make that become something that, if people use it, they can get remarkably better results. But the kinds of things that we've had, difficulties with is how do you get a much larger percentage of people to adopt it? So in our work, for example, we've run a trial at the Dana-Farber Cancer Institute where this is related to my book Being Mortal, which was where I interviewed people who took care of people at the end of life better than I did. And Susan Block was one of the people I interviewed, the head of palliative care at the Dana-Farber, and she explained what a better end-of-life care and really what a better conversation about any serious life-limiting illness is. And that conversation involves your being asked what your priorities are besides just living longer. What are you willing to sacrifice? What are you not willing to sacrifice for the sake of more time? And then tuning the care to your answer. Pretty simple and straightforward, you'd think. Making that conversation happen was brutally difficult. We found ways to hone it down to a 2.5-hour practice session where a clinician would try having the conversation to break bad news to somebody and come to a decision like a cancer's come back, what are we going to do now? Here are the options. What's the way you would normally have that conversation? Now try it by asking these questions. And rolling it out took 3 years to ultimately get to the place where, for the intervention group, so we randomized the whole institution and 80% of the clinicians participated. Half of them got the training and reminders. And they did ultimately get to 92% had this conversation that wasn't happening more than a third of the time. And preliminary data is, the results is the people who had those clinicians had half the level of depression and anxiety in the course of their care before they came to the end of life. They had planning occur earlier before the end of life, less suffering overall, and no evidence of harm to their, and less cost, by the way, and no evidence of harm to their survival. But now we're taking it wide in England, starting in Liverpool, in Massachusetts here with a series of hospitals starting with Lowell and Leahy hospitals, and in Texas, in the largest health system in Texas, Baylor Scott and White. And taking it to scale, despite the kind of evidence you have and despite the kind of benefit you can see from it, we have not learned how to tell who the early adopters are from who the late adopters are going to be. So you asked that question earlier about resistance. So the result is that we can be working with people for 2 or 3 years before you figure out that they aren't going to be successful with you. Mm-hmm. So the sort of set us up for the big next problem is, like in South Carolina, I would have loved to have known what were the hospitals from the beginning that were not going to be successful, that 60%, and why, and work on that reason. Is it because your culture isn't ready to accept it, and why, and what can we work on about that before you even try to make the change? Or is it because your leadership isn't genuinely committed, and how do I expose that? I'm looking at Asaf Bitan, who's one of the primary care doctors who works with us, and he created a map of Haiti as part of our work in primary health care, and found that a map of every primary health care institution in Haiti and what their variation is in their ability to provide good primary health care. And one of the sort of really intriguing elements to me was that there's really wide variation in how well they do. One of them was a tiny percentage get client feedback. Like, that's the indication of a pretty interesting group of leaders there, that they actually ask their patients, what are we doing well, what are we not doing well? And that's an indicator of something. So I feel like that's a clue to the next line of work, is how to unlock.
The idea being that the kind of person who wants to get feedback is the kind of person who would be more likely to embrace new ideas and be self-critical.
Yeah, so that's the group you want to start with.
Yeah.
Maybe you get client feedback, that's an indicator. But second, is that now something you can apply a tactic to and you say, hey, let's not work with you let's work with you to start accepting client feedback.
Oh, I see.
And could we turn people into early adopters? That's the thing that's stymieing us, is how do you make it so they can go from being late adopter or middle adopter to being early adopter? How do you make them more likely to change their mind?
Do you have are there any other kind of in little markers like that you've found over the years?
So our Better Birth team, we just finished a trial in North India that is the largest maternal health trial in childbirth ever done. It was with 120 hospitals, 160,000 births. And there was wide variation in their ability to take on this checklist that we had implemented. And we were doing it by introducing coaching, which is sort of a novel idea for us in medicine. The idea that you would have a coach who comes and observes you and gives you feedback about what you're doing. So we were trying that method. And we asked the coaches early on, what's your gut on whether this is going to work or not? And they were very good at predicting, like we had all kinds of surveys that told us, that gradually showed us who were likely to adopt and weren't. But their gut instinct within the first 2 visits was, or early on anyway, was accurate about who was able to take it on and who wasn't able to take it on. And so then our leader of that work, a woman named Catherine Semrau, asked them, debriefed them, what were you noticing? What gave you that gut feeling? And one gave us this clue that's totally stuck in my mind, that when they walk through the primary health center and they walk through the labor and delivery room, she would smell to see if she smelled bleach. And if she could smell bleach, that meant it was a place that could keep the place clean, which meant that the sweeper and the nurse and the leaders somehow worked together. And if that was a place where they could work together, now this was a place that could work together on something else. Mm-hmm. So that was like this great clue. I don't know what to do with it yet.
It's the version of the apocryphal story about the green M&Ms and the
brown M&Ms.
Brown M&Ms.
And the David Lee Roth, Van Halen. Yes.
Do we need to explain this? Perhaps. The story about how David Lee Roth would require in his contract that backstage he have brown M&Ms in a bowl, only brown M&Ms. It's not because he's into brown M&Ms. He's into his stage show is so complicated that it requires an incredibly competent crew to make it happen. And if they can't get the M&Ms right, he knows they can't possibly get his stage production right. Bleach is the M&Ms.
Exactly.
Yeah. Not sure that.
Now, what you do when you don't smell bleach, though, like what he would do is he would just throw a rock and roll fit, right? And say, shut the place down and wreck it, and then they'd get on the news about, these crazy Van Halen guys that just shut down this whole thing, when really it was just a good business decision.
Yeah. This is also why I like to hire assistants who can drive a manual transmission. Because these days, if you're 22 and you've taken the time to master what is essentially useless, for the, on the odd chance you're going to be stuck in Europe, and the only car available to drive your honey to the hospital has got a manual transmission, you totally want that person as your assistant, right?
That's the best indicator of total anal retentiveness.
That's right, exactly. I wanted to go a little bit deeper with this and talk about the underlying problem here in a lot of this is not just the bias that we have towards the breakthrough and against the follow. The glamour and the glory is with the breakthrough and not with the follow-through. The glamour and the glory is saving...
Which I don't understand, right? Apple is all about the follow-through, for example. It eventually became the winning story.
Yes, a lot of this is specific to your world, but it's specific to the kind of the various reward systems that are built into complex fields like medicine. But I'm wondering, hypothetically, totally hypothetically, should we take a breather from the new in order to, like what if we said, this will never happen, but suppose as a thought experiment we said, all right, for the next year, we're not awarding any more patents. And we're not allowing you to publish any articles on new ideas.
And FDA is going to approve no more new drugs.
Only on old ideas. You can talk about, you can do redo versions of old ideas, but nothing. Is that I realize it's never going to happen, but just to play with that notion for a while, do we need to think of some version of that to get us away from our infatuation with the fancy toy?
The power of it could be, the question is how you would make it so you would displace all of that energy onto the, for example, our biggest killer now that smoking is down is high blood pressure. We have a third of our adult population has high blood pressure. It is the cardiovascular disease is our biggest killer, and high blood pressure is now the biggest driver of that. It's also the biggest driver of dementia. It's the biggest driver of strokes. So only 40% of the population has had their blood pressure, that has severe hypertension, has had it recognized and has it under control. Kaiser Permanente was the first group I saw do this. They said, we're going to solve this problem. And they got it up past 80% and drove cardiovascular disease in their population from being the #1 killer in their population to dropping it so low it became #2. And then Minnesota took that protocol and rolled it out through community health workers in different places. Let's measure your blood pressure and then stay on you to keep it on. Cut the doctors out of it. Let's make sure we have people who simply work their way through an algorithm and get it under control. And they became the first state that got rid of cardiovascular disease as the #1 killer. So this is more lives than you can possibly save with the next discovery by any means. Now, I'm not convinced that the problem is that we've displaced all our energy from the new discovery, right? There are lots of reasons why under the age of 75 people die from conditions that we have not got the answer for. But there's something true about the idea, part of what I've been interested in is like, how do I make solving these problems more sexy? Like, how do you make a checklist sexy? And how do you understand the idea that it's another form of control and influence and innovation and cool opportunity in the same way that finding the next drug is? And I'm not sure it's a simple act of displacement.
Would it be, if off the top, let's play with a couple of hypothetical ideas.
Okay.
Assume I give you a very large pile of money. What if we double the salary of primary care physicians and halve the salary of medical specialists? Does that reverse the polarity of some of these problems?
So we're kind of trying this experiment. So we've got this cool experiment in Estonia, right? Estonia, after the wall fell, after the Soviet Union let them go and become independent, they decided the Soviet model was built almost like an American model on the specialist and the hospital, virtually no primary care. Estonia decided they didn't have a future trying to build the system to follow our path. They didn't want the cost and thought it could be more effective. So they started giving incentives where they paid the primary health care physicians better, and they successfully over a decade have gotten 50% of the specialists to convert to primary care. Gave them a staff member, a nurse who's kind of essentially like a community health worker, to focus on, let's work ahead on our population, not just wait till they come in, let's try to address certain problems. And they didn't really have a protocol for doing that, so not much has happened. So we ended up partnering with them and the World Bank in this large experiment we're carrying out, starting with a corner of the country, a subset of the practices, and then trying to measure and take it outward. So we have that experiment underway, and it is perfectly possible. It seems apparent to us that it is perfectly possible to rebalance the weights here, right? There is no reason that we're in a situation right now where the highest valued people are paid 250% more. The top are orthopedists, interventional cardiologists, plastic surgeons, radiologists. And the very bottom, the lowest paid in our system, is the pediatrician, Next up would be like a rheumatologist, a psychiatrist, HIV doctor. Basically people who take care of people over a steady period of time. So those who are rescuers are more valued. Those who are incremental preventers are not valued. And yet the value chain has switched so that computation has allowed us to act well before, and now add in genomics and add in big data and other things allow us to act in front. So I think we're seeing already you can add a lot more value along the way. The puzzle of it is, what happens politically? Like, you can generate all of that benefit, but what happens politically? Like, there is absolutely no political backlash for the fact that the Republican budget, in their repeal efforts, would eliminate $1 billion in CDC funding that has already demonstrated a reduction of between 50,000 and 100,000 deaths a year from improving the safety of care and improving certain kinds of infectious disease and cardiovascular management. So the challenge is that, yes, you can make those policies, but will we be able to sustain the political will to do it?
Do you, and this is a question, a devil's advocate question.
Okay.
But I'm wondering whether our discussion, the centrality of health insurance in our discussion about health in general, is a symptom of the same problem, right? Because if you were thinking about systems that exercise and diet, $1 spent on exercise and diet has an infinitely greater contribution to human health than $1 spent on health insurance, right? And yet when it comes to talking about health, most of the oxygen is taken up in arcane discussions of what form the insurance should take.
Well, there's two things. One is that we could spend a lot of money on diet and never change behavior whatsoever. It's one of the fields in which we have the least demonstrated mechanisms. Like, who knows if a sugar tax is going to be successful in getting people to actually, it's worth the evaluation that you try it and you test it out. The second thing is, I think you're right, though. Did an analysis with a Republican economist and Democratic economist where we looked at the last 10 years of insurance expansions published in the New England Journal in the spring. And so when Medicaid expands or the ACA expanded, one of the things that happens is lots of people are able to get their emergency care, and we found no mortality benefit from doing that. So within a year afterwards, you don't see big mortality benefit. You see that people aren't bankrupted when they get their emergency care, so people's financial condition improves considerably, bankruptcies go down, but their lives aren't saved. However, what we saw was if you have a regular source of care from a clinician who's familiar with you and can afford your needed medications, after 4 or 5 years, you get substantial reductions in mortality. And the greatest reductions are in conditions that are chronic. So HIV, cancer, heart disease. And the mortality reductions goes up by 1% a year for each year thereafter. And so the mistake that we're making is insurance is premised on the idea that what you need is that rescue, that life is a steady period of health, momentary episodes where you want to be rescued, get brought back to that, and continue onward in life until the next episode. And instead, what that indicates, our data was indicating, is that life is the steady accumulation of health issues, chronic health issues that add on as you get older. And if you're in getting steady, regular care, you are able to put them off for longer and manage them better so that you have a better outcome along the way. But it is so suddenly insurance makes no sense. You need a mortgage. You're investing in actions now that won't benefit for 5 years, or 10 years, or 30 years. And in fact, the amount of benefit goes wider and wider as you go out. And so, our whole healthcare model has to be one that insurers, people switch insurers all the time. Insurers have little interest in making investments now for the sake of things later, like cure hepatitis C, have the cure now. Hepatitis C now for tens of thousands of dollars. Avert $1 million of cost 10 years down the road. why would we want to do that? That patient they're not going to be my customer 10 years from now, so why do I care?
Yeah.
And that's the problem with insurance.
Yeah. Wait, I feel like, how long do we have?
I think we have, do we have another 15 minutes, I believe? Yes, 15 minutes.
At some point we could take questions.
At some point we have to what?
At some point we could take questions.
Oh man, you totally escaped.
Well, I'm happy. You have every right to ask me a question. You just haven't so far.
Oh yes, you only batted me down when I started to.
No, I'm kidding. No,
We should entertain questions. We can do that.
Yeah.
There are ways. I think there are mics, right? Yeah. And then we can keep riffing.
Okay.
Okay. Can we bring a microphone to the person here? That looks like a microphone. Here we go.
Have you talked to malpractice insurers for being advocates of the systems or processes that you have developed, if only because they would be painfully aware that in any malpractice case, the plaintiff's going to walk in with an expert who's going to cite to your systems as a standard, and therefore not following them is going to be negligence.
So the really interesting thing is that they were our first group willing to fund this work, because they are willing to invest in problems that are years in advance. So, when someone is sued, it's multiple years before it even gets settled and everything else. So, Harvard's malpractice insurer, called CRICO, the Controlled Risk Insurance Corporation, was the group that allowed us to create a partnership of all of the Harvard hospitals and surgeons around what's been this great collaborative where we tested out the checklist. But then, our latest thing is we're now testing bringing individual coaches into surgeons' operating rooms. We're just starting to roll out an experiment where surgeons would let us bring, from sports, can we allow the idea that we would put a coach in the operating room, watch how you operate, and give you feedback on how you do everything from teamwork, situation awareness, to technical matters of how you've carried out that work. And so, yeah, and interestingly, what they've built in is, just like fire insurance, they give a discount for participating in this work that we've been deploying. So it's been
It's
great.
interesting because we're in a political moment where there is a worrisome and sometimes to some extent puzzling resistance to the concept of insurance, to the notion that we are all that the healthy subsidize the sick, that we're all engaged in a common collective enterprise. But I'm wondering whether insurance becomes a good deal more politically and socially palatable when the insurer is actively engaged in driving system improvements. In other words, if my health insurer was someone who was doing what you're talking about, was clearly and transparently trying to fix these kinds of neglected systemic issues, maybe my resistance to participating in risk pools would be diminished. Is that fair or not?
What do you think is the reason why there is that backlash? Why is there that idea that why do the young and healthies? The thing that I think about is this backlash that says that if you're healthy, why should I pay for people who are sick? In total disregard of the fact that every one of us will not be healthy forever, and we're bound to become sick and then be in that need. And so why does that the question is whether your answer serves the diagnosis. So what is the basis of the problem in the first place?
Well, the basis of the problem is not wholly irrational, right? It is, you can, someone who is blessed of a family background that is without major genetic mishap, and someone who is in reasonably good health in their middle age, and someone who is above average income, and someone who is not overweight and exercises and eats fairly well, can reasonably be sure that they will have a lower lifetime medical bill than someone who has chronic diabetes and has any number of other, right? I mean, they don't know for certain, but they know as a general. So there are people, it is absolutely the case that the medical insurance system, by definition, is about a class of people subsidizing another class of people. So there's no way around that. So I think that the only...
But your class of people subsidizing the other people is in a very narrow frame, right? Every one of us basically accumulate chronic health issues and will become in greater and greater need of the pre-existing condition. And then add to it, like, I could do a genetic test at any time, and then we're all pre-existing conditions waiting to happen. And
I see. My issue with this is that I think that the argument that people make in defense of insurance, which is that you may need it too one day, you're going to be sick, doesn't work, because it is a fact that a small number of relatively identifiable people are going to drive the overwhelming. You've written about this. The overwhelming majority of healthcare costs. The better argument is
following your article about $1 Million Murray.
Yes, but. It's not good. The better argument is a moral argument. And this is what frustrates me about so much of public policy. There's no way around the fundamental moral argument. You do it because that is the part of the cost of being a citizen in a free society. You protect people who are less fortunate than yourself. Like, it's not about you. That's the answer. We don't construct a health insurance system for the healthy. It's not for you. Get over yourself. Like that, and why our complete inability to say those simple words, get over yourself, frustrates me to no end.
Yes, the idea that everybody gets the better deal.
Yeah. No, they don't.
So it's a part of the interesting thing to me in this piece I wrote last week for The New Yorker was going and interviewing people who I grew up with in Ohio, many of whom voted for Trump and some of their friends and so on. And that you had all of these arguments about, I don't want to pay for this person or that person. All of them supported Medicare. And why did they support Medicare? And the reason they supported Medicare is that it was different. So if I go in saying, you deserve, like, do you think people deserve a right to health care? And what people hear that as is, I'm going to have to pay for somebody else. And, so I'm talking to people who are, many of them earning less than 20 bucks an hour. They have they've paid half their paycheck for taxes and a health insurance premium that is for a crappy health insurance with a $3,000 deductible. And then they're watching their taxes pay for someone who is slightly poorer than they are, get Medicaid coverage that they can't even dream of having, no premiums, no copays, no deductibles. And it just pisses them off. It makes them very bitter about the idea that it is a debate about who's deserving and who's not deserving, whose life is valued and whose life isn't valued. And when you say, well, then why do you support Medicare? And what they'll say is, well, that's completely different. We all paid in and we all benefit as equals. And I think that the core problem is that the system from the get-go, the moment, from the time we've tied what healthcare you have to your job, has meant a world of winners, especially the college-educated getting the much better coverage in those jobs, those who are not college-educated having worse coverage or no coverage, and then trying to cobble together systems around them. And then you feel like you're in one of those airport boarding lines, like I'm in zone 5 and the people in zone 7 are cutting ahead of me, and so screw them, why should I be paying for them, and this isn't fair. I think that it ties into what you're saying, that if we were building a system towards the idea that we are all contributing and are all benefiting, that's more likely to be a world where the core value you're voicing is that all lives should be of equal worth, and they do not feel, the working class that voted for Trump, many of whom voted for Obama, do not feel that they have a life that is of equal worth in this system.
The interesting thing that you're getting at, and I'm wondering if you can comment on this, is whether there is a connection between the point you just made and the broader argument that you've engaged in your career. That is to say, if we had a system that was a medical system, healthcare system that was constructed along more, shall we say, morally palatable lines, would systemic approaches to improving the outcomes be easier? Do they make more sense if the system itself has at least the appearance of fairness?
Absolutely, yes. So one of the things I think that, one of the interesting things to me is that you measure levels of trust in various kinds of people in society, and they've all declined, except in the healthcare world. People still have very high levels of trust in doctors, nurses, pharmacists, and so on. And I think it's partly because of two things. One is that when you come into a hospital clinic, we have a presumption that your life is of equal worth. There's a gap between that aspiration and the reality, but we're embarrassed by it. And we don't believe that that's the way it should be. You don't buy your way into getting the first operation the way you buy your way into the front of the line at anything else. That idea allows there to be trust, I think, in the second part, which is that there is imperfection in what we do, and that we're constantly striving and innovating to get there. And it's a sort of unusual world. We usually face off the idea that egalitarianism is in opposition to innovation and dynamism. And healthcare is a world where we are doing both. We're committed to innovation, committed to driving our system for better and better, transparency, having data, all those things. But it's in the name of a system where those values are at stake. And if you don't talk to those moral values, if you don't express it and hold yourself to them, then why would I trust the data? Facebook or anything else, when they have data about your lives, it's appropriately mistrusted because you don't trust the values that underlie what is being done with it.
Should we take another question?
Another question.
We have time for. Right. Wait, I shouldn't be the one. I'm not wearing my glasses, so I can't see anyone. So I shouldn't be the one pointing.
Why aren't you wearing your glasses?
Thank you. I'd like to ask a question about the system, because Partners has recently adopted what I think is the ultimate system of EPIC, which has come into our lives in terms of how we take care of patients, how we document things, and the lists in EPIC. But in contrast to what you talked about in terms of a huddle where people are talking to each other, you're looking at a computer. Do you have any thoughts about how this is going to change how the practice of medicine, but also is this an added value to the care of patients, or is this going to be something that's going to be a problem in terms of mistakes that are made, that are carried forward by copy and paste?
So this is a really good topic, because this is you can help me, because this is my article I'm working on now. Why do computers suck? Like, we hate it in medicine, and why we hate it. And I think part of so I have a theory why, and I'd be interested in yours as well. So the computer system is constructed primarily, there's really great things the computer system does. By putting our prescriptions on computer, we've cut errors more than 90%. Like, no more scrawled prescriptions that lead people to getting the wrong drug or the wrong dose and all those kinds of things. So there's good things that happen, and communication happens much, much more widely. Back in the days when, the chart would sit on somebody's shelf and no one knew what was in it, was a disaster. That said, the computer is built as a billing system. The single thing it does well, I can send a bill in under 3 seconds. It's the one thing, it is not hard for me to figure out how to send that bill, and minimum number of keystrokes. We got sent a corrective that we are entering our allergies wrong. And so I got a 5-minute video that I have to watch and train me about the 17 keystrokes I have to make to enter and change the allergies patients have correctly. That's just terrible design. Why would that patient care not be designed that way? And the reason why, I think, is because it is hard, and it was never built for that purpose. And second of all, people don't have a conception of what it is now to take care of people. People are a complex project unfolding over time with lots of people involved along the way, and the computer is built around the billable encounter. And the billable encounter is the office visit, and it's the lab thing and the next item along the way. But there is no story that you can find in the computer of the patient and our interaction as a group of people around that person. And so we spend, I'm a data entry clerk, you're a data entry clerk, this is what we do now for half of the visit with people. It doesn't enable us to have a stronger relationship and to be able to manage with that person this project call the accumulation of their health conditions. And so my theory is it was built for another purpose, which is improve billing. That's what our system, that's the core incentive that we're
Well, if you ever,
trying to
it's- when you go to a convenience store and you buy a bottle of water and a newspaper, and there's 48 keystrokes, whereas 25 years ago you just handed over $3. That's because it wasn't, same reason. It wasn't designed to smooth the interaction between the cashier and the customer. It was designed as an inventory system, an automated inventory control system, and also to keep track of the money that's coming in. So it's the same general problem that people who write software do not necessarily have our interests at heart.
Yeah, what was the moment, though, when the grocery store realized, oh, if I smooth this interaction...
I didn't know that they had realized that.
Well, when they gave me my little Apple Pay thing, didn't that help?
I don't know, maybe we're
going to the wrong grocery stores.
We're going to different grocery stores. I think,
Oh, it's time.
I think that's it.
Yeah, 23 seconds. Any last words, Malcolm? You're going to tell us about yourself? What's your next book on?
This reminds me of a guy I knew.
Tell us about what your next book is
A lovely person, but a great solipsist, who would have lunch with me and would talk nonstop for an hour. And then he would signal for the check, push the check towards me, and say, "So, what's going on with you?" Thank you all for coming. It's been lovely.